I think my claim to fame has only been that unlike specialists in gender, I see a whole range of human beings, and I think that gives me a perspective beyond gender.
It fits very well with the theme of our podcast, does it not? Beyond gender.
Beyond gender.
There you go.
Paraphilia as a diagnostic category is not immutable, but it's changeable. And I think there are some people I've worked with that I've helped them to understand their paraphilia, and it's gone away. God damn you, Dr. Levine. I can't do this anymore. You ruined it for me. And I said, and so what's happening between you and your wife? Oh, we're having ordinary sex now. And she thought I was the greatest, you see, because she knew there was something really weird about this otherwise nice guy.
Let's say you are put in charge of fixing it. How would you fix it? Or what's the best way to guide us out of this mess?
This question is above my grade level here. If you do believe in science and the possibility that science is more likely to produce of a useful truth than other approaches, then we should apply these approaches.
Hello.
Hi.
Hi.
Lovely to see you.
Good to see you.
Good to see you two again.
How are you?
I'm pretty good. Can't complain. Working hard. Playing hard.
Good.
Enjoying my life. Yeah.
Good.
You still see patients like full-time, part-time, a little bit?
No, full-time. Monday to Friday. Usually by Thursday, next week is empty, relatively empty. By Monday at noon, I'm filled up. I have one appointment left in the next 10 days because I'm going to be away for 5 days. But I'm very busy. And I would like to slow down, but people keep calling me. You know.
Do you see predominantly trans-identified patients, or it's a broad?
I see. I just came from a couple who's 94 and 92, and that was my last patient. And before that, I saw an 18-year-old who was exhibiting himself and got into trouble. And before that, I saw a 58-year-old man who's homosexual in his orientation and married a woman for a beard, and now he can't stand how defective she is as a person. And so I see a full range of human beings from trans teenagers to people in the geriatric. When you practice psychiatry for a long time, your patients get old with you, and they bond, and then they don't want to leave. Or they come back.
Wow.
So I think my claim to fame has only been that unlike specialists in gender, I see a whole range of human beings, and I think that gives me a perspective beyond gender.
Oh, that's funny. So do I. I continue to see people beyond gender, and it suits me. Because it reminds me, it doesn't let me go into this exceptionalism of, gender, it's like no other distress. It's like there's loads of ways to have distress, loads of ways to manifest really odd behavior and fixation. So that's so interesting.
Yeah.
I didn't know we shared that.
And it fits very well with the theme of our podcast, does it not? Beyond gender.
Beyond gender.
There you go. Excuse me, sorry. Stella and I were talking just before you came on, Dr. Levine, and I would like, if you'll permit me, I would like to start our conversation by picking up where you and I left off in Lisbon, because we were sat next to each other in Lisbon, and as is the way in these conferences, you have lots of half conversations, and then you get interrupted and pulled in another direction. I really wanted to finish the conversation because it was interesting. So I'm going to refresh your memory. Don't worry. I think I had embarrassed you a little bit by doing my Stephen Levine fangirl routine. and you were very sweet, and you asked me, why do you admire me so much, which I do. And I replied that it's because in everything you say and everything you write, it comes through so clearly that you have such a deep understanding of the human condition. And you replied, that's because you've studied sexuality for decades. And then I got pulled away, and that was the end of the conversation. So my question that I wanted to ask, is that the key to understanding humanity? Is that the key to understanding people, is to understand sexuality?
Well, I think it's a sliver of humanity. As everyone has a sexuality, 9% of people have alcoholism, or 2% of people have schizophrenia, but 100% of people struggle with sexuality. And sexuality is always a struggle sometime in the course of life for everyone. So we're, you and I are very familiar with the struggle of coming to own one's sexuality in adolescence, and the feelings of guilt and desire, and how they conflict with one another, and how one manages oneself as a civilized person and as a non-destructive partner. So these are adolescent struggles, but then, people bond and they marry and they have great expectations, and then they get disappointed and their partner is not the sexual being that they imagined and they wanted and they needed. Then we get older and, menopause happens and the penis becomes unreliable a few years later. And so... But this is just one aspect of a human life. But what has made that an opportunity for me is that people are, even professional people, are hesitant to penetrate the barrier of privacy. And so they misunderstanding human beings in their aspiration to love and to be sexually fulfilled by not talking about it. So in my field, people talk about anxiety, depression, psychosis, and drug addiction. We talk about the catastrophic endpoint, the suffering that comes about from a pathogenesis or sequence that is not discussed. And so I've become, in the Cleveland area where I'm from, I was originally the sex doctor, and but I also was a psychiatrist who took care of other forms of suffering. Like, I'm really unhappy with my child is not doing well or whatever. So I don't think it's the secret for understanding human suffering or human life, or human aspiration and its frustrations. But I do think it's one approach, it's one avenue. Now, I'm mindful that when I was a resident in psychiatry, my teachers were all Freudians. And so we read Freud. I was we used to have a Wednesday seminar once a week, and we read Freud. And this was a three-year seminar. And Freud has 23 books. His collected works are 23 books. So Freud thought in 1905, I think, he said the royal road to the unconscious was through dreams. And I've been thinking about that phrase, the royal road to the unconscious. Well, he could have said the royal road to the unconscious is sexuality, you see. Or he could have said the royal road to the unconscious is anything, anything he would have chosen, you see. Because all of us, and one of the problems with the psychoanalysts is that they can't distinguish between that which is so private the patient doesn't want to share versus what is unconscious. So the analysts tend to think, oh, it's unconscious me. It's unconscious. And I think, well, I don't know about that. People have a lot of sexual thoughts and fantasies, and it doesn't, it's about men and women. It's not just men, you see. And so the royal road, I think, is to a caring, non-judgmental, interested relationship, and people will share. Now, I can tell you that even if people trust you or me, that doesn't mean they're going to tell us everything they know about what's shaping their behaviors. You see? So I've been with people for 20 years, and then finally they tell me something that they've been withholding for 20 years. And I'm sure, Stella, you've had the same experience, right?
Yeah.
So what is unconscious, the royal road, what is private, and in human sexuality, in terms of our impulses and our behaviors and our sense of ourself, is private, and it requires trust to share some of that privacy. When I was a medical student, I thought it was wonderful to be a doctor because people would tell you everything. And now I look back and then it was so naive of me. You see, I was 22 years old or something, 23 years old. And so now I have a more humble respect for what I don't know and what people won't tell me. So if you had such a positive view, of me, I think that's because I think it's because so many of our colleagues only take a superficial view of the human soul, of the human predicament, of the human process. And it's not like I understand it. Is that I I'm honest to say I told my 18-year-old today, I'm a student. You may think I'm a psychiatrist, but I'm a student of your kind of behavior. I don't understand it. And had you seen me 30 years ago, I wouldn't have been able to tell you what I know about your behavior. Like I've already told you what this is about. And I explained to him that, and I taught him this word, multifactorial, that all behavior is multifactorial. But when you focus in on an individual behavior, there are multiple meanings to that behavior. So there's an aggressive aspect to it. There's a please see me and love me and admire me. There's a fix the fact that I'm socially, I'm on the outs and with my peers. You see, there are all these layers embedded in a behavior, which in turn is multifactorial. Now, I'm willing to say these kind of things. Does that mean I understand those factors or the meanings? No, I'm just seeking them. Maybe that's what you like about me.
I think it is. You can apply all of what you just said, the multifactorial aspect, to a trans identity, could you not?
Absolutely. As Stella and I have been saying for years, this is no exception. These are human beings.
Right.
There's something you said there, let's say an exhibitionist presumably has a fetish or is a paraphiliac. Do you differentiate with people who have paraphilias or who have fetishes? Generally, people think that general received wisdom is that they don't move beyond it. They stay with their paraphilia or they stay with their fetish and it doesn't leave them. Do you take any position on that?
Well, number one, your question is a little surprising to me because I thought you were going to say, what do you think there's a relationship between the trans identity and paraphilia? But I'll answer your question. Let me see if
you can do both.
I can see if I can remember the question.
I want to know, do people grow beyond? Because there's a very definitive. People don't think that once you got a paraphilia, that's it. You've got a paraphilia for life. There's nothing you can do. There's a lot of people are saying that.
No, I don't think that's true. When I was young, there was a prominent sexologist named Gene Abel, Abel, and he and a younger woman colleague whose name I'm blocking on at the moment did a study of paraphilia. And they took histories from people who were arrested for paraphilia, and they found out that it's not like you have one paraphilia for life. That many people with paraphilia change their paraphilic interests over time. So the paraphilia as a diagnostic category is not immutable, but it's changeable. And I think there are some people I've worked with that I've helped them to understand their paraphilia, and it's gone away. Aggressive paraphilia. I mean, without giving you case details, I do have this idea that in seeking to understand the origins of paraphilia, it is possible to help people outgrow their interests. One person who married a young, recently married man introduced his wife to wearing boxing gloves and Everlast boxing shorts, and he wanted to pretend like they were boxing as a prelude to making love. And so they came to see me, and I thought, well, I've heard some stories, but I'm telling you, you never.
There's logistical problems that I can foresee here, but anyway, keep going.
So I'm talking to him about, and his wife about this, and he tells me a story about how his father used to call him a coward because he wouldn't fight other kids who were pushing him around on the playground. And he personally wasn't a boxer. It's not like, but he imagined himself to be, a pugilist of great power and victorious. So he actually bought his wife boxing gloves, and he wore boxing gloves, and he wanted her to wear this particular short called Everlast, which is a boxing thing.
I know. Yeah.
So I told him what I thought this was about. And the next session, he came back and said, "God damn you, Dr. Levine. I can't do this anymore. You ruined it for me." And I said, "And so what's happening between you and your wife?" "Oh, we're having ordinary sex now." And she thought I was the greatest, you see, because she knew there was something really weird about this otherwise nice guy. No, I don't have a 20-year follow-up to tell you what happened to him. Our great stories in psychiatry are dependent on not having follow-up.
Yeah, I know. It is. It's very sad. Do you think that with fetishes, do you see it as a block to intimacy? I see it as it's a kind of, it's not. It's a way of being invulnerable. It's a block to intimacy. It is a block to a deeply intimate relationship.
Oh, Stella, you and I are kind of unknown souls.
Art and ways.
I've written a number of books and about love, and in my chapter on paraphilia, I begin it. I wrote a book called Barriers to Loving. Number one, that was one of the titles, Barriers to Loving. But in my most recent book, when discussing paraphilia, the chapter on paraphilia, I discuss 9 meanings of the noun love. What is love? There are 9 meanings to that. And then I discuss the processes of love. And after describing love from both a noun aspect and a verbal aspect, I then introduce paraphilia. And once you understand what the human aspiration to love consists of, you can see that a paraphilia is a barrier, is an intrapsychic barrier to bonding, to connecting to a person, to having a rich interpersonal, fraught with danger relationship. And so that's why I say you're kind of soulmates. We're the kind of soulmates because you recognize that paraphilia is is an impenetrable barrier to closeness and the growth of love over time. And I can tell you, as you could probably say as well, countless examples of how paraphilia interferes with a partner's ability to securely attach and to feel known and valued and ultimately loved. And then it robs the person of the sense of optimism about going through life with this person who can't. Like I remember one woman realized, my husband used to buy me bras and panties, and he would make love to my bra, not to my breasts. He didn't want my breasts. He wanted my lacy bra. You see, that's an example, I think, of what you're talking about.
To me, the most extreme and destructive paraphilia is autogynephilia. Would you, perhaps because it comes with the medical pathway that just creates so much destruction in the man's life and probably his intimate relationships. Do you agree? And do you think there's a way to help these men without going down such a drastic medical pathway?
GenSpec's Bigger Picture conference series returns for its fourth landmark international event this September, the 27th and 28th, Saturday and Sunday, in Albuquerque in New Mexico. At this time, we're not just analysing problems, we're shaping the solution. We're looking for a way forward, and we've chosen the best speakers, the best leading thinkers of our generation to discuss how we can move the dial. With the theme Live Not by Lies, Conversation for a Culture in Crisis, this year's conference tackles one of the most urgent challenges of our time: how to speak truth in the face of conformity, confusion and institutional pressure. As the politicisation of sex and gender continues to divide societies and derail thoughtful discourse and destroy loving and engaged families, this groundbreaking counterpoint to WPATH brings together the world's leading thinkers, clinicians, policymakers, lawyers, politicians and psychologists to forge a path that is ethical, evidence-based and grounded in reality. Dr. Lisa Littmer will present her latest groundbreaking research. Lionel Shriver lays bare how society's fixation on trans identity distorts truth and undermines fundamental freedoms. Peter Boghossian will present Truth Over Lies, Bold Conversations in a Fractured Culture. Dr. Patrick Lappert will discuss the impact of trans surgery, while Dr. Quinton Van Meter will discuss the impact of hormones. Following defining events in Killarney, Ireland, in Denver, Colorado, in Lisbon, Portugal, we're now coming to Albuquerque in New Mexico. This is more than just a conference, it's a call to action. Join us for 2 days of unflinching honesty, rigorous evidence and solution-focused collaboration. It's time to move the dial and you need to be in the room. Visit genspec.org to secure your place.
Mia, the only disagreement I have with your sentence is the word most.
Oh, really?
Listen, there are men who get off on raping. There are men who get off in physically harming and choking and sometimes snuffing. So I'm what do I say? I'm really sensitive to the destructiveness, not only of love, but of the dangers of having a failed love, you see. So this is just another way of suffering. It's a way of suffering that we see in the gender world. We have autogynephilic men who are so terrified of an actual relationship, they become the woman that they desire to be able to love. But the actual fleshy woman next to him, just forget it, honey. I'm too scared, but I don't know that I'm too scared.
Yeah.
So that's destructive to him because he has an aspiration to have the benefits of connection that evolves over time. And it's, of course, very destructive to her because she's married. She may even have children by this time, and he's lied to her. He's withheld this aspect of what turns him on, you see, and so she's betrayed and trapped, and so that's very destructive, of course. But most, I don't know. You might not.
Okay. Take out most.
Yeah, just take out the word most, and yes, I'm a soulmate with you.
But then because I find that I'm often, every time I try and think the medical pathway and the whole thing all the way through, I always come to the conclusion at the end that this is just not medicine. It's just not an appropriate way to treat a paraphilic desire or a psychiatric disorder, and it just doesn't seem like real medicine. It doesn't seem like a well balanced way to handle someone's distress. But I've always thought that perhaps you were a little bit more in favor of medicalizing these men. Is that true?
No. Well, I guess maybe it's sort of true, sort of not true, or sort of true. I would say that my approach to psychiatric treatment of the problems that come to me begins with the grasp of the pathogenesis of the problem. What are the multiple forces that are shaping the current state of arousal, or what you would, autogynephilic arousal? To me, the treatment begins with understanding. It doesn't begin with surrender to getting whatever you want. See, I think what we're trying to do is create a happiness in a person who's not very happy and who is thinking about destroying himself. Now, going back to Stella's question that she didn't ask about the relationship between gender identity problems and paraphilia. Transvestism, before we had this word autogynephilia, was recognized over 120 years ago as closely related to masochism. I don't know if you know that, but that's...
Did not know that.
No, I didn't know that.
So in looking at cross-dressers at the turn of the 20th century, Freud and others had noticed that men who cross-dress were often interested and excited by the idea of masochism, their being a masochist. And so if forget about autogynephilia and let's go back 120 years, you see patriarchy, people, the intellects of the day basically thought that men were superior and women were not, and that they were defective in some way. Or Freud even wrote, he thought at one time that women were morally defective, right? So that's why women hate Freud today. One of the reasons. Anyway, but the idea that I cross-dress means that there's something wrong with me. I want to be a woman. I'm not an adequate man. And I'm more feminine in my interests, and therefore I'm defective. And if I'm defective, perhaps I need to be punished, or I hate myself for my defectiveness. So what we have, now we go up to 1989, 1990, and these men say, I love my defectiveness. I love my femininity. I want to be able to express my femininity. Okay. But really, you're not, if we go back to love, you're not doing this for anything but to solve your own internal self-hatred. And so it is a disguised form it may be a disguised form of self-hatred or masochism. See, Freud confused the world because he said there was sexual masochism that was relatively rare, although he didn't know about the internet and in people looking at sexual masochism. But there was what he called, and this is what confused everybody, moral masochism. Now, moral masochism was people behave in ways that put themselves in harm's way because they feel guilty about something and they're unconsciously, or what I would say privately, punishing themselves for their interests, their capacities or their incapacities, you see. So today, if a boy admires feminine things, he doesn't have to be a trans person. He can admire feminine things. He doesn't have to hate himself if he grows up in the right family. I know in the family I grew up with, I feel like I much more like my mother than my father, right? But that no longer disturbs me, you see. But I remember denying that fact when I was in college. I couldn't tolerate the idea that this boy, this Stephen Levine boy, who acted like, felt like, behaved like, related to other people much more like my mother did. And when I told my two roommates that I was much more like my father than my mother, both of them exploded in laughter. Exploded in laughter. See, you're nothing like your father. You're just like your mother because they spent time in my home. You see? Anyway, they were right. But I look back on that and I say, I needed to bolster my masculinity, my sense of myself, you see? Because when I was in college, most of the guys that I hung out with, all they did after they studied, they wanted to go to the bar and drink beer. And I went to the bar with them in my freshman year, and I ordered a beer, and I couldn't even finish my beer. I didn't like beer, right? And I thought, "What is wrong with me? All my peers are drinking beer, sometimes 2 beers before they left the bar, and I couldn't even finish a half a beer." And eventually so I was kinda worried about this. And I think it's ridiculous now, but it's the truth. I was worried. What was wrong with me? I didn't like beer. And actually, the end of the story is 18 years later, I went to England and I had a glass. I went to a bar and I had a pint of warm, dark beer. I thought it was the best thing I had tasted in years. Right?
Maybe it was Guinness. And the masochism, I just want to go back to masochism for a second, because there's something almost masochistic, well, very masochistic about the way I'm thinking of the trans men, the female to male, the way it nearly feels like there's this extraordinary pleasure they get in the pain and humiliation of their scars and showing the way there's something masochistic about the way, I don't know if you've seen it, Stephen, online. They show their scars and they show their pain and they show their medical transition in graphic detail. It feels like a strange, it feels almost pornographic the way they show their scars. Do you agree with me, Mia, in the way the trans men are showing their scars and their medical transition? There's something strange about it.
To me, it just seems far more tragic than pornographic. That's all I see. It's women in pain.
Well, I suppose I'm thinking
masochism.
Masochism.
Yeah, I'm not.
Thinking of pain and humiliation and kind of a sexual surge or something like that. Maybe I'm wrong.
Oh, I've never looked at it that way. What do you think, Stephen?
Probably get shot for that.
No. What I think is that I spend a lot of time with very sick people. And eventually in very sick people, I see an exaggeration. I mean, mentally ill people, psychotic people. And eventually with many of those people, I think, oh, I recognize this. This person has 10 times the intensity of this idea that I have and other people have. You see, it's not that he's not understandable. What's making him crazy is the intensity
Yeah.
of the concept that he has. So, you know, if I had to fight my feminine identifications with my mother, right? I fought it. I accept it, you know. Um, my mother used to like to have people talk to her, and they would spill the beans to her, and here I am, a psychiatrist, right? So what I'm saying is that even the understanding of the profoundly impaired human beings, we recognize that they're human beings. They have more of something that most people have, more intense, more intensity. Um, even even kinkiness is found in some little degree in everyone. Uh, we're all very curious about all of our orifices, and none of us are naturally faithful. You see, we have hunger for novelty. Uh, so um, so the question is, how come? Let's just presume that the three of us are reasonably normal people. What that means is that we have all these impulses that those quote people that we're calling abnormal, or those people who suffer. You see, we have somehow been able to balance those same impulses or tendencies and maintain a stability of the sense of self and to conduct ourselves in a civilized way with other people without, suffering endlessly. See, um, well, um, that that's what I think is the product of spending time with people who aren't doing well and listening to the anguish of their soul, so to speak, and what their concerns are about. And and in some way, I think that's the answer to your question. I don't think it's a direct answer, but maybe you should ask me the question again because I think I got derailed.
Well, I know, Mia, you have a few questions about DSM and WPATH
I
and things like
do.
that. I know you want
Yeah,
to. Yeah.
if that's all right. So as you know, I wrote the WPATH files report, and I wrote this. It was a big trying to tell the story of WPATH. And then after the report was released, I must have done. It feels like I did hundreds of interviews, and in almost every interview that I did, I would start off by talking about Hibigda, the Harry Benjamin International Gender Dysphoria Association. And I would say that I believed Hibigda in the early days was at least trying to pursue something like real science, or trying to find the best way to help these individuals in this particular state of distress. And the reason I always said that is because you were in there, and I felt that you are a principled individual, and you would have been trying to help these people. You were not on some crazy ideological quest. So I'm curious, what can you tell us about the early days of Hibigda? What was it like, and when did it go off the rails?
Well, I think I think I was part of Hibigda starting in about 1974, 1975, right after my residency. Maybe it's 3 years later. I can't recall. And I was interested in what parents are interested in when they have a teen with transgender. I was interested. What's going on here? You know, why are these men? Why are these middle-aged men saying, "Take off my penis and give me a vagina and let me live," or "I'm going to have breast augmentation surgery so I can have a double D cup that I can show off to the world." See, so we were surgeons and psychologists and psychiatrists, and an occasional hormone doctor, endocrinologist. We were gathering together every 2 years to answer the question, what the hell is going on here? Right? And what should we do about it? You see? So I thought we were serious. Now, I wouldn't say this was scientific. I think this was clinical science. And so even back then, as a young man, I was interested in the pathogenesis of that is how things got to be, what shaped us. I was very interested in our fate. I was very selfishly interested, what is going to become of me over time? You see, so I had to study other people to understand that, right? It's very selfish of me, see? Uh, so, so in those days, we had surgeons who were explaining what they did, and what they could do, what they did do, and then we had certain, like I remember a Swedish psychiatrist did a follow-up study of 15 people who had surgery, and so to me that was the clinical science, right? It was the follow-up. If you wanted to do surgery, what's the outcome? And so I remember the conclusion was the outcome was worse if the surgical result was not cosmetic. If there were complications, people didn't do very well. And they didn't say how well people did when there weren't complications. But what was clear is that the people who are unhappy with their trans journey, the surgical journey, had to do with their labia sloughed or their vagina closed or they had urinary problems and so forth. By the way, urinary problems after vaginoplasty, after genital surgery for either one are so common, and I think the world has not appreciated that. In part because the patients get their surgery in Belfast and they go back to London or they go back to Cleveland, and so the original doctor doesn't know anything about it. Anyway, Hibigdo was a group of people, multi-specialty, who met every 2 years, and were reporting on their clinical experiences. And somewhere, I would say, around the end of the century, Richard Green became the president of Hibigda, and Richard was the world's most famous sexologist. And he was a prodigious, very smart guy and very productive. And he took it into his mind, actually much before the end of this century. He took it into his mind that the thing to do with these people was to give them surgery. Because I was at a big meeting and I presented a presentation of 88 men we had seen, and I divided them into, I'd say that almost all of them had what I called in those days character disorders, and a third of them had conspicuous character disorders. That is, it took about 5 minutes, 10 minutes, and you knew there was something really disordered about this person. Those are mostly men. And the other group had character disorders. They were just a little more subtle, passive dependent personalities, paranoid personalities, and so forth and so on. Richard Green responded to my talk afterwards. We were standing around at a cocktail party, and he said, he said, number one, you don't have a control group, which was true. It was just my cohort of the 88 patients that we had seen. And then he said to me, if you did 88 cab drivers in New York City, you would find the same thing. And then what really I remember this, he looked at me and he said, Steve, why don't you start studying bipolar disorder and leave this field?
Wow.
So anyway, so this was probably in 1990, in about 1988 or something, maybe 91, 92. So I thought there was a commitment back then, probably 10 years before when I was the head of the Standards of Care Committee for the Fifth Committee, when I presented it to him, he got really upset, and he said, you still recommended 2 letters for hormone treatment, 2 separate independent groups, professionals had to say they thought this was a good idea or a reasonable idea or shouldn't stand in the way. And I said, that's what our committee decided. Now, our committee did not use any science. It was all, what do you think? What do you think? What do you think? And so he said, well, you've done this work. This is the 5th standards of care. We accept them. But as soon as my gavel goes down, I am appointing a new set of committee to do the 6th thing. And if we look in 2002, the next committee said one letter of needed only. And basically everything else was word for word what we wrote in the 5th committee. So,
And this,
so then I realized we weren't interested in what's going on here. We were interested. The leadership was interested in advocating and the experiment of giving more people surgery so we could learn, does this help people or does it not help people? But again, his criticism of my work, which is correct, there was no control group, right, is exactly the same thing that his policy, his advocacy was aiming for.
I don't think I've given Richard Green enough credit then when I tell the story of WPATH's pivot, but correct me if I'm wrong. So he was the sissy boy. He did the 20-year prospective study of the sissy boys, the famous study. And was that not the purpose of that was to find so-called transsexual children, intervene earlier on in order to prevent transsexual adults? Was that the motivation? Because it seems like he really changed his tune, if that's correct.
No, I don't know if that was the motivation. The Sissy Boy Syndrome book, which I think was published in 88, 89, it was a follow-up study, a bi-coastal follow-up study of kids that in New York and in LA, what happened to them without intervention. And I think, if I remember correctly, 2 of the many, many children in the 20-year follow-up were trans-identified, but the vast majority of the trans-identified children outgrew it.
Homosexual. They grew
White.
up to be homosexual. I think it was just one ended up trans-identified, if I remember correctly. Okay, maybe I misinterpreted his motivation for that study. I thought the whole point in the beginning, the search for transsexual kids, was a way to intervene and prevent transsexual adults, because medicalization and living that kind of lifestyle was not considered desirable. And then at some point it flipped and it became a human right and something to celebrate.
Yeah, that was decades later. Yeah. I can't comment on that. I don't know the motives for the study. I mean, to me, the study was really important that sissy boy syndrome meant homosexuality for the vast majority of children, not transsexuality, which I think is a very important empirical finding.
Yeah.
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 Huge.
So you left Hibbig. You saw it turn to move away from anything resembling science and far more into political activism. Would that be fair? And then you left.
I left in 2002, which was 3 years after Richard Green. It was right after the new standards of care came out. But the reason I left is I went to the meeting in Galveston, the Hibigda meeting in Galveston. And that, I think, was the first time that there was a large percentage of cross-dressed men in the audience. And when certain ideas from the podium were stated, many people in the audience booed. And these weren't professionals who were booing. These were the cross-dressed men. And I remember riding back to the hotel with one of these cross-dressed men. I must have given a talk there. I can't exactly remember, but he said to me, I mean, it was clear he was a man dressed as a woman. He said to me, "I wish I could have you for my therapist. This is really painful." But you see, in the public sphere, to boo at a professional meeting, and no one, in Bigda was, listen, you can't boo, that's not appropriate. See, when I go to the Cleveland Orchestra, I know there are people new to the orchestra because they applaud after the first movement of Mozart, right? And it's like, we don't say anything to the people who are applauding, but the applause dies down very quickly, you see. But in a professional organization, we do have rules that we don't need to boo, and we don't need to boo repeatedly. And because I think from the podium after being booed, I cut out a paragraph because I didn't want to be booed again. You see? And this is not how clinical science operates. This is not professional. And so it was tolerated. And so I think the final straw was the booing. And I said, I can't, if I want to know what's going on here, if I want to know how best to treat these people, I can't be part of this. So
do you think, I certainly do, but do you think that is what went wrong with what became WPATH a few short years later, is opening up the membership and allowing a whole bunch of people, trans-identified people, with a certain worldview and a certain understanding of their own condition that just came to dominate? Is that what went wrong?
I think that's part of it. But if Richard Green told me to go study bipolar disorder and not waste, not interfere with these people's lives, I actually think I was helping these people. See, I mean, maybe it's my illusion, you see, because they call me I'm a hateful guy or something, but I believe I've been trying to help them, and I just see the pain of their lives, and I'm trying to modify that pain. I'm trying to understand the sources of the pain and what they could possibly do about it. You see, I recognize that even though we have the absence of follow-up on people who've transitioned, the impression I get from the people that see me who have transitioned, I'm aware of their pain. I'm aware of their limitations, you see. I'm aware of their barriers to being loved. And so I kind of laugh at the idea that people hate me because I think it's a sign that they don't understand. They don't talk to me. They hate me from a distance, so to speak,
Do you think that medical transition can be a healthy and helpful intervention?
For whom?
Anyone.
Of any age.
Anyone at all. I just can't see it. So do you think it benefits anyone?
You see, everyone has multiple aspects of their life, and this is a sector of their life. What to do? Let's just pick on males for a second, biologic males. What am I supposed to do with my inclination, my envy, my admiration, my wish to inhabit the styles of women? What should I do with that? Now, if we only focus on that, transitioning with hormones, with surgery, if we only focus on that sector of that person's life, yes, he could be happy, especially in the short run, because this is as the people say, this is a lifelong dream of mine. And so it's a dream fulfilled. But then let's say that during the process of getting that dream fulfilled, the person is preoccupied with this, like 93% of his energy is about this. And so he achieves his dream. I dreamt getting into medical school. And so I got into medical school. I was really happy. You see? Then I had to rotate through this. I wasn't so happy. Yes. So if you look at the sector, the answer to your question is yes, I think people are happy. But if you look holistically at the rest of their lives, I'm not so sure it has afforded them success in the rest of their lives. That being said, I remember years ago, I helped a woman become a man, and she had a wonderful marriage. And I presented her to Grand Rounds one day, and everyone laughed when she said she was paid $28,000 when she was a woman, and then she came to work, and a year later in the same job, she got $10,000 more because she was a man. Everybody laughed, and then there was like laughter, and then, well, what does this mean here? What's going on here? You see, what's wrong with our society? Where the skilled person, she was a very mechanically skilled person, got paid more because she was presented as a man. So, so I'd say if you look at the sector only, the answer can sometimes be yes. And if you ask that person about life, are you glad you did this? Yes. What price have you had to pay? What price did you pay for doing this? Oh shit, you know. My children don't talk to me. My daughter went psychotic when she heard I did this. You see, I lost my job, and my best friend.
And the psychological strain of presenting as something that you aren't. I sometimes think it's underestimated. Now that I work so much with detransitioners and they talk of the exhaustion they felt, almost always trying to be something that they weren't.
No.
I feel it's quite debilitating.
You've just reminded me.
Yeah, go ahead.
There's a lovely paper that was written in the 70s. I think it's Mayer and Hoops, one of the earliest papers. And there's a gorgeous sentence in it where it's like, in 1,000 subtle ways, these men know that they are not women, and they experience it in all of these, in their interactions in life, and therefore it cannot bring them peace. And that's why McHugh ended up shutting down Johns Hopkins. But I think there's got to be something to that. You're living a lie, and that's got to take a strain.
Yeah, so the way I say this is that when you're young, like when you're a child or when you're an adolescent, you actually believe that you are the opposite sex. And, we have the Ashleys of the world and some of the people who are saying, well, sex is not binary. They're just, and this is all biologic stuff, all this crazy stuff, right? But as that person grows and inhabits the trans life, they come to inevitably a greater sense of reality to then qualify for what you just said, man. That is, it can begin with a false belief that it is possible, and I am born in the wrong body, and I am truly a male or a female. Yeah. And then you live your life, and then reality and maturation, whether it's the brain's maturation or just life experience, it teaches you. And so I've heard people say decades ago, well, I'm not a man, I'm not a woman, I'm really a kind of a third sex. I'm sort of between, or I recognize, like one of my trans people, adults, 42 years old, rides a motorcycle and is a pool shark. And when someone at a pool convention says, you're a guy, come on, right? She cries, right? She likes to maintain the idea that though her body is male, and She has estrogen breasts, and presents herself in female clothes all the time. She is aware that she made this decision because she's happier living as a woman. She is genuinely happy or living as a woman, but I have her on 4 different psychiatric medications. You see? And so she can't sleep and she can't pay attention and she's depressed and on. And she's already had gallbladder operation and renal cancer at 42. And we wonder, what the hell is estrogen having to do with the problems that she developed? But if I ask you, yes or no, are you happy that you did this? The answer is absolutely yes. This is myself, whether it's biologically determined or not. I am happier. I think of myself as a woman, but it's one of great fear of being mistreated, identified, bullied, commented. No, people don't bully her; they just make a comment. You see, like, are you competing as a man or a woman? Well, that undoes her. So I think there is a constant fear of being read and unaccepted.
Mm.
And I think that comes with the territory.
And do you think the insistence, this, yes, I'm happy, don't regret it, do you think that's a large element, the power of irrevocability? Can't turn back the clock, so you're going to have to keep telling yourself that you made the right decision?
Yeah, So I once had a discussion with a psychoanalyst who had spent 2 5-year periods of time in psychoanalysis with 2 different analysts, seeking some kind of peace. And he told me, listen, after you spend so much time and energy and money pursuing cure through psychoanalysis, you got to believe it's helpful. You got to believe it was the right decision. Now, I never forgot that because I thought it stood for everything. That once you invest yourself in something, you see, I joke with my residents after we hear a very difficult life. I said, there's still time to be a dermatologist. You see, I once gave a little talk to a bunch of women lawyers, and I never, in the discussion period, I never saw a group of professionals who hated their professions as much as these women divorce lawyers. Right?
Oh, yeah.
It was just amazing to me. So listen, but once you're a divorce lawyer, you got to have a major change in your life to leave what's called family law in America, right? But people do make changes because they regret their decisions that they made. All of us can regret decisions. The most common thing we regret in life is who we married.
Is that true?
The divorce rate.
Yeah.
Right? Okay. Well, why did I think this guy was Mr. Perfect? Turns out he's cross-dressing. So you see, this idea that we hear all the time that we have noise pollution, that there's only a 2% threat rate. It's ridiculous. See, we see people throughout the life cycle. We see that people talk to us about their regret. In a sense, everyone comes to see me, talks to me in some way about their regret. Oh my God, how did I get into this? What did I say? What did I do? What did I think? You see? How come I went to law school? How come I went to medical school? How come I got married to this person?
There was something you said earlier that's kind of stuck with me, that, they started booing in the Habigda conferences. Like, we're talking the early noughties. And was this part of a general movement where lived experience and sufferers of conditions were attending conferences, while maybe prior to that it was just professionals who came? Was it specific to gender that suddenly that there was trans people in the audience, or had we gone to a bipolar conference at the time or other conferences, might it have been, was it a new growth of sufferers, the lived experience cohort, attending conferences?
In my experience, like I'm going to the American Psychiatric Association meetings tomorrow, and uh, uh, we don't have schizophrenics come to our session on the medication of schizophrenia. I mean, just as an example, it's not like that we're insensitive to the suffering of schizophrenics. Now, the good thing about Habicca, I would say, is the having people there was a reflection that the transsexual community itself needs to be represented in discussions about social policy, legal policy, and medical policy about transsexual people. So, for example, in the 8 other people who were in the 5th Standards of Care committee, that we had a trans person. So I think there ought to be some representation of people who have the lived experience and help us professionals not make too many errors. However, I once had one of my patients come to our gender committee, and everybody we presented this person said she's not a true transsexual. She doubted everyone. She was the example of the true transsexual in her mind. And eventually I stopped inviting her because I thought she was too prejudiced. And that particular person suicided eventually. She and I wrote a paper called Increasingly Ruth, toward
Oh,
understanding sex reassignment surgery. But she could not function in our psychiatric team because I thought she was very prejudiced. In order to justify her life, she had said all these other people were frauds. And so,
I always fear that that's part of it, though. The number of trans-identified people on the inside of WPATH who've made the medical decisions and they've gone down the one-way path. I feel that they're on the inside and perhaps there's a lot of self-deception and they're convincing themselves that they made the right decision, and therefore the standards of care have to reflect that medical intervention is the only way because that's the route that they took. Is it beneficial to have so many trans-identified people setting the standards and on the inside shaping these policies?
I don't think it is. Remember how I objected to one word most? Now I'm objecting to. You see, the idea that there's only one best way to treat these individuals that they don't know. You see, this is ridiculous. One word tells me that not to believe what precedes and follows the word. There's only one way. Now, I have been treating these people, been trying to help these people since 1973. Thank God, that's 52 years. There's not only one way to treat depression, schizophrenia, alcoholism, marital discord, picking one's nose in public, and so forth, right? So where do we get this authoritarian, only one way? No alternative is what they're saying. No alternative effective treatment, even though you don't know whether this is an effective treatment. And in what sense is it effective? In what sense is it not effective? I mean, it used to be that 25 years ago, I think probably even less than that, there are people who say that this is a cure for gender dysphoria. I mean, DeVries said that she cured gender dysphoria. He didn't cure gender dysphoria, right? There's no gender dysphoria. There's no trans person who's been medicalized who's free of gender dysphoria. It improves gender dysphoria. You don't like your breasts? We take them off. You don't have breast dysphoria anymore. You still have gender dysphoria, right?
It can improve gender dysphoria, but it very often doesn't improve and could arguably exacerbate. But we do look at interventions in the whole, and we, for example, lobotomies, and we say we tried it, it was very invasive, and on the whole, not a good intervention. We need better. You know, the radical, the extraordinary nature of medical transition, it's so huge that arguably we need to review the entire concept of this intervention.
So it's a classic example of medical misadventure. See, I've asked the question in a paper in 1999, how many people have to be harmed by a treatment intervention before we stop the intervention for even the people who are benefited? You see?
Great question.
So this was 1999? I think it was 2009. Anna Solomon and I wrote this paper called The Meaning of Psychopathology. And it was like a retrospective review of the last 10 patients we saw in our clinic. Anyway, in the last paragraph of that paper, we asked this question. And see, if I'm a cardiologist or a neurologist and I shoot certain material into the brain of people who look like they may have had a stroke, and 3% of those people have a stroke after that, and most of those people die, we are never going to, and it's 97% of people do fine, right? We are never going to do that test anymore. We cannot afford. So I know this about the pneumoencephalogram. So I asked this question: is it 5%? Is there a threshold of 10%? How many people, where this is clearly a disastrous intervention for them, before we say, whoa? And I say that, number one, the 2% business is a lie. It's just a lie. But we as a society or a group of professionals interested in this, the apologists and the skeptics, together, we should answer this question. And then we should do studies, you see? But I think the threshold for harm should be very, very low. That is 3%. That's pretty bad, right? Now, they're not just suicide, within a week. But if we think, see the argument that we have this elevated suicide rate within 10 years. You see the argument, it wasn't because of the trans, it was because of other things. Well, it's hard for me to think that when you live 10 years as a trans person and you give up on the future, that it has nothing to do with trans life. So did I lose the question?
It's not. And did you say Andrew Solomon you wrote a paper with?
No, not Andrew Solomon. Anna, A-N-N-A.
Oh, because I was thinking Andrew Solomon, who wrote a very interesting. I just read it recently. He wrote a book called Far from the Tree. It's another. Anyway, he wrote a chapter of trans.
That's a great book.
Yeah, it is a great book. Anyway, irrelevant. Have you any last questions, Mia? This has been so fascinating.
It has. Let's say Dr. Stephen Levine is put in charge of guiding us out of this mess. We're helping. Obviously, everything. It's gender medicine is broken. It's not working in the way that WPATH and has led the field into. Let's say you are put in charge of fixing it. How would you fix it, or what's the best way to guide us out of this mess?
This question is above my grade level here. My pay.
Hypothetical. It's hypothetical. You're in charge.
It's a wonderful question.
You can do it.
I haven't thought about that question. I've been too busy just presenting the unknowns in this field, which is what I do. How to get out of this mess? I think we could start with a random a survey that's done methodologically correctly, a randomized survey of people who've made a transition. And we should get a control group that may be their siblings or someone born at the same time, the same birth week, the same year, and the same community. And we should study them carefully about at least 7 or 8 parameters of their lives. And we should somehow be able to, with scientific, with numbers, because we love numbers in science, right? We need to compare those two, you see? Because I know that I once was in a legal dispute, and the person, the psychiatrist, the child psychiatrist on the other side said about the medicalization of trans youth that they can have a full, successful, satisfying adult life. We are enabling them to have a full, successful, satisfying adult life. Okay, so what I said was, well, I'm glad he thinks that, but we don't know that, right? And we have certain indications that it isn't true. So I think we need to start with a carefully designed but randomized, not self-selected, of people who are advocates or who just, like those other surveys. So that then gives us some data. Now, I'm perfectly happy to say if the data shows that these people are pretty much the same as the control group and they chose to do this, then let's start. Now, I know, and I don't believe that we can have placebo-controlled trials of puberty blockers and cross-sex hormones for youth, but I do think, and I may be methodologically unsophisticated about this, I do think that if we told the truth to the parents, that we're not certain whether this is the right treatment, then we could get, in a multi-site way, we could get hundreds of people who are considering puberty blockers or cross-sex hormones, depending on the age. And we can, if they agree to be in a study, we can randomly assign them to 3 groups. Intervention, as is currently affirmative care intervention, psychotherapy only, and doing nothing, watchful waiting. And I think if we follow those people, even for as limited time as 5 years, and we have at least 80% who stay in the study, I think that's as close to a randomized controlled study, a scientifically acceptable study. In other words, my answer to your question is do science. Don't do opinion. Because for everyone who thinks this is a great deal, a great thing, I think there are probably 25 people who think morally, ethically, just intuitively, what you're doing, what? You're taking the breasts off of a 14-year-old girl who says, I don't want to have children? So I say, if you believe in science, and in America, we don't believe in science anymore. You see what Trump has appointed. We have all these people who doubt science, right? Who doubt vaccines and so forth. But if you do believe in science and the possibility the science is more likely to produce of a useful truth than other approaches, then we should apply these approaches. Now, in the meantime, what legislatures are doing in America, half the legislatures in America have said, you may not give anyone hormones and puberty blocking hormones less than 18. No one. You see, this is the result of the failure of science to lead the way. The legislatures, often very religiously informed, think this is a moral outrage. This is destructive to family function, and it's destructive to the child who wants this. And so they need to be protected. And you know what? Those legislators and the governors who signed those bills, they believe you can't trust the doctors, which is not good for the medical profession. They can't. The government is saying you can't trust the doctors, and you see, I want to be trustworthy, but I realize I have limitations, and I tell you, people call me an expert. I just love this. People call me an expert, and I tell them, what is an expert? And I say, it's a person who knows what is known and what is not known about a very narrow subject. See, I seem to know what is not known in the field. And so I'm an expert. I am a genuine expert, but I'm not, because I'm a psychiatrist, I'm not an expert. I may know more about the treatment of depression than someone off the street, but I'm certainly not an expert. I'm a relative experienced person, but I'm not expert. If I'm expert in the trans world, I'm expert only about what is not known. And see, I don't have the problem that the average mental health professional has, like when I take care of other problems. I have more knowledge than the average person, but I'm not an expert in schizophrenia. I'm not an expert in eating disorders. I'm not an expert in the treatment of cocaine addiction. See, I know a little bit about it, but, I often refer people to someone who has more experience and more knowledge. It's hard to find experts in those subjects, by the way, in any city that you live in, because in America, we have a huge number of people, but the experts in a subject may live in Missouri, and I live in Ohio, you see, so I can't refer them easily. So I'm looking for Cleveland experts. Expert is in italics, meaning they just know more than I do, but they're not necessarily expert in terms of what is known and what is not known. So the answer to your question, Mia, is it rests on my faith in science.
We do know Dejna, like 2011, she did that study. It was a 40-year kind of analysis of people who medically transitioned. And, the results were not good. It was kind of from 1970s to the early noughties. And they, 19 times more likely to die by suicide. So were more likely to be admitted to a psychiatric hospital, more likely to be imprisoned, more likely to be admitted to a hospital. There was a lot of very, very bleak information in that study. Now, it wasn't a control group. It was compared to the general population, and that's how people say it's a flawed study, because these are inherently distressed people because they have gender dysphoria compared to the general population. But I like it as a study because I think it shows that this is a very, very difficult medical intervention that I think we need to highlight that it's arguably causes more trouble.
I like that study. I quote it all the time, and I criticize the 6 or so authors because they had a chance to study the people who they didn't accept for sex reassignment surgery, and they didn't study those people. So the 347 people they reported on, they had a larger number of people in Sweden that were applied to the national bank, the national group, the committee, and said, no, you're not ready or you can't have it. You see, that to me, that was the natural control group. And I'd say, if you put so much effort in doing this study, why not have this? And I've never had an answer to that question.
Tragedy.
Yeah.
Can I just add one thing, then I think we'll have to let you go. But when you're saying you
don't let me go, please don't let me.
Well, for everybody who's listening, you're going to be speaking in Albuquerque, and it's going to be a great title. Great talk. It's called at our conference in Albuquerque, the end of September, it's GenSpec conference, and the title is "What Parents Should Know About Psychotherapy for Their Trans-Identified Adolescent."
Okay.
And I think that is going to be extremely helpful to a cohort, which is the parents who are really need a hand. I really feel that they're being left on their own, and it's a very scary position to be in, to be a parent of a trans-identified.
If you want to look at the source of suffering in trans world, you don't have to simply look at the patient.
No. That's a quotable quote.
Yeah. Can I just add one thing, though? I just want to ask one question. Because of the science, you really want, you think the answer is science, but I have this, I don't know, I have an aversion to the thought of any kind of even good science when it comes to puberty blockers and this intervention for youth, because of everything that we actually already know about adolescent development it seems to just be completely unethical to even consider doing that trial, is it not?
I too am aware of the limitations of science and the weak relationship between public policy or regional policy and scientific findings. We have to look no further than 17 systematic reviews that have not influenced WPATH at all. Right? So, and even the advocates, like those 8 people who did the Yale, the Integrity Project, science has no, they can dismiss science with one sentence,
Yeah.
Anyway, I'm hesitant to say what you just said. I feel what you just said. I actually think that as a public policy, given the uncertainty, it's reasonable to ban the use of puberty blockers. I think it's very reasonable to restrict the use of cross-sex hormones. I accept 18, but I don't like 18 because I remember being 18. You see, when I was 18, I thought I was just like my father. So I'm trying to maintain a kind of neutrality about this. I'm trying to say, what do we know? Let's not be too rash. But I recognize, I think at one of the meetings, it might have been Lisbon, my first slide was there were 8 perspectives on trans care. One of them was a moral perspective. One of them was an ethical perspective. They're different, you see. Those 26 legislatures in the United States, I'm telling you, it's on a moral basis. They say it's a Christian basis, but it's a moral basis. It's an intuitive thing. What are we doing to children, preventing them to have puberty because they're afraid of puberty? That's what we're doing? Are you doctors crazy? Or are you just immoral? Or do you think you know things that general culture doesn't know? See, so I'm ambivalent. I recognize you were describing a portion of my soul, Mia. I actually think there's very little question that we should be using puberty blockers. But if we insist on if we have people who have good credentials and who are well-intentioned and who actually believe this and who tell us that I've given this to 20 people and 19 of them have done beautifully. I think if they're not crazy, if we believe these people, then I think it's reasonable to use science. Now, I think the UK is trying to do a study with puberty blockers, and the people who've seen the study have thought, "What?
Oh, it's a disastrous study. It's a terrible.
This is not a study."
It's terrible.
No. So bad
Oh,
science,
it's a disaster.
bad science is not science. You see, as when I talked to you about the cross-sectional study, I said it has to be methodologically good. It has to be good. We have to agree before we even begin. We have to have a consensus of experts, not proponents, experts in methodology, epidemiologists. We need to invest in the science, but because science doesn't have that, especially in America now, science doesn't have much credibility, and so public policy. I've never recommended, I've never cooperated with a mother or father who wanted their kids on puberty blockers, and this is before, 20 years ago. I think it's just intuitively that the trouble is, see, I'm a parent. I think I know about the unpredictability of human development from childhood traits, childhood wishes to adolescent traits and adolescent wishes to adult traits. I think being being a number one, a person, and number two, being a parent, and number three, being a doctor, and number four, reading the literature, it tells me we shouldn't be doing this. But we're doing it.
At the moment. Thank you, Stephen. Thank you so much.
Thank you so much.
It's really, really fascinating.
Yes. Thank you.
Good seeing you both.